Hello everyone. Welcome to the second month of our online nurses training course on essential newborn care. Now, after learning about normal newborn and initial management of a sick newborn, now let us start the second month with the module on breastfeeding and lactation management. A great pleasure to welcome Professor Dr. K.K. Divakar, one of the senior-most neonatologists of the country, and his team from MOSC Medical College, Kochi, for leading the discussions on this module in the next 3 days. Over to you, Divakar sir.
Namaskar and greetings to everybody from MOSC Medical College, Kolancheri at Kochi. We will be taking a session on breastfeeding today. And our doctors will be discussing details of breastfeeding, rather an overview of breastfeeding. This is so important that we can call it only an overview because there is no way that we can cover all aspects of breastfeeding, however simple it may seem, for the satisfaction of everybody. Our team of Dr. Leela Kamath, Dr. Roslyn, and Dr. Manu would be taking detailed sessions for everybody, and I'm sure you will all enjoy it. It is also a pleasure for us to come out of the areas of the neonatal intensive care unit and take sessions that are truly interesting and more important for the society at large. When we mean breastfeeding, we have to understand that yes, undoubtedly it is the best feed available for a baby. But for most mothers, especially the primipara mothers, it's more like a beast feeding, a crying baby. They get frustrated. What should I do with this baby? How can I manage this baby? And it is always considered that in breastfeeding, the adequacy of breastfeeding reflects the inadequacy of the mother. And the poor mother is under a lot of stress because she is made to feel that she is at fault if a baby is not feeding properly. What we must ask is, babies cry when they are hungry, but do babies cry only when they are hungry? Is it proper for us to trust the mother better rather than trying to force her to say that, okay, your baby is not having enough breast milk and start feeding? So these are very common problems that we all face in our day-to-day practice and also in our own lives. Whenever a baby is crying, you say breastfeeding. And this is controlled by many factors. It's mainly based on the maternal experience. You can have a crying baby who comes over, the mother doesn't know how to handle it. But if she's a multi-gravida, she probably knows exactly how to handle it because she's already taken care of it earlier. But then we have family interferences coming, parents, grandparents, in-laws. We have overbearing well-wishers, the neighbors who will probably come and tell you how to feed a baby. And the most dangerous of all is a misinformed health worker, because when the mother turns for help to the health worker, they have to give the right advice. So at the end of the session, what we are trying to do today is convert and see whether we have an informed health worker who would be very comfortable in giving the best advice to a mother when she's seeking out breastfeeding. I do have a video at the end of this session. If possible, we'll play it for you. Otherwise, please type out breast crawl in the internet and you will get this video which actually tells you how wonderful this is all for everybody.
Hello everybody. I'm Dr. Leela Sudhakaran from Kolancheri. You've already heard the introduction from Dr. Divakar. We are talking about breastfeeding and lactation today. I'll just start sharing my screen. Okay. So, once a baby is born, everything is supposed to be normal, isn't it? Because breastfeeding is supposed to be such a normal phenomenon. A baby is born breathes, has no distress. And the next thing is for survival that they feed. But sometimes that doesn't work, and we need to know what are the things that we have to do to make life easier for the baby. Okay. So the talk today will be benefits of breastfeeding, basic breastfeeding positions, what do we mean by a baby-friendly hospital, common breastfeeding problems and how to tackle them, and breastfeeding in the times of COVID. The first three topics will be taken by me, and the other two by Dr. Roslyn and by Dr. Mann. Now, as you can see in nature, there's a cow, this is baby, her baby. It's an elephant with her baby. And some species of gorilla or chimpanzee, I'm not sure, with her baby. So breastfeeding is every baby's birthright. So why can we not, why do, you know, sometimes we give other milk to the baby, but that's not correct. I'll tell you why. Now, if we see human milk, is there any contamination? No. Animal milk, there is formula. Yeah, when they mix it, there may be. There are a lot of anti-infective properties in human milk which are not present in both animal milk and formula. Growth factors. The protein in human milk is the correct amount. It's easy to digest. Whereas animal milk has got casein. We have whey in the human milk. They try to make that in the formulas, but at the end of the day, what is custom made for the baby is obviously good for the baby. Then breast milk will have enough of essential fatty acids, which are not present in animal milk and needs to be added. Iron, even if it may be less, it's well absorbed and is adequate for what the baby requires for the first 6 months. And that is not the case in the others. And similarly, except for vitamin K, all the other vitamins are there. And water is also enough. A baby does not require anything extra. So at the end of the day, it's tailor-made, it's free, it's cheap. So the advantages are that it's got perfect nutrients, it's easily digested, it protects against infection, costs less, helps in the bonding, helps delay pregnancy. We'll go to that a little more detail. So as I said, the benefits of breastfeeding are not just to the infant, but to the mother, the family, and to society. Breast milk and colostrum are made for babies. It's the best first food. It's easily digested, well absorbed. Contains, as I said, the essential amino acids for the baby. Rich in polyunsaturated essential fatty acids. And there is better bioavailability if the calcium-phosphorus ratio is normal. It protects against infection. It prevents allergies. Babies and infants who have been breastfed are said have higher IQ points. So there is better intelligence. And it's also been shown to decrease the incidence of heart disease, diabetes, and lymphoma. Even as the baby gets older, there is decreased prevalence of obesity. There is some risk, decreased risk of childhood leukemias. And even for development of the mouth and jaws, there is decreased risk of dental occlusion, but not beyond 2 years. Okay. Now for the mother also, because oxytocin comes into play, there is a decreased risk of postpartum hemorrhage, decreased delayed onset of menses because of lactational amenorrhea, decreased incidence of iron deficiency for the mother because she doesn't have her periods, and what is known, as I said, lactational amenorrhea leads to family planning and child spacing. Then long term, there's decreased risk of breast cancer, ovarian cancer, uterine cancer, and decreased risk of central obesity and metabolic syndrome. Then if you look at it from the mother to the family, because breastfeeding is free, the cost of versus the cost of formula, the cost of incurring disease because of formula feed, decreased emotional stress, And to society, again, mothers healthy, babies healthier, there's lower healthcare costs, higher work productivity, and environmentally friendly. There's no waste, no product transportation or packing, and no land needed for grazing cattle. Now, within human breast milk, because of the fact that it's custom made, milk which is found in a mother at term is different from milk which is found in a preterm baby. Within within a mother herself, the first milk, which is known as colostrum, is different from the milk that comes in later, and even within one feed, the foremilk is different from the hindmilk. Okay, so the variations in the composition of milk, colostrum is the milk. Let's see if I can just highlight this. Okay. So colostrum is the breast milk that women produce in the first few days after delivery. Thick yellow in color. It has a lot of increased immunoglobulins, proteins. Mature milk is the breast milk that is produced after a few days. Foremilk is the one that's before, and hindmilk is the one that's produced later. Hindmilk is the one which comes later, is whiter because it contains more fat. And it has, because of that, it actually gives more of the energy in a feed. And we have to always make sure that the baby takes all of the foremilk and the hindmilk. Foremilk looks bluer than hindmilk. It is produced in larger amounts, plenty of protein and other nutrients. He gets all the water that he needs from it, and they do not need any other water. Okay. So as I said, as you can see, a preterm baby, baby's mother has more protein in her milk compared to a term. So a term will be around 1, and in a preterm it will be about 2 grams of protein. So that is because the baby requires more for growth as a preterm. Now, okay, so these are the differences in the milk. Now let's talk about anatomy of the breast and physiology of lactation. This is the breast, and these are the mammary glands. Okay, and these are made up of these are the lobes of the mammary gland, and these are made up of lactocytes. Now, what happens is from here the lactiferous ducts are formed, and they open up at the nipple. From puberty onwards, these increase in size, and during pregnancy, obviously, each of the alveoli in the duct keep increasing, and milk is secreted in here in the alveoli, and this is mainly under the influence of prolactin. And then through these ductules, they reach to the baby under the areola. Okay. Now, physiology of lactation means, the other one was the anatomy, this is physiology. So we need to know how milk lactation occurs, and this is under the hormonal influence in the mother and also reflexes in the baby. There are 2 main hormones. There are lots of other hormones, but the main ones are prolactin and oxytocin. Prolactin helps in the secretion of milk. Both of these hormones are secreted in the pituitary. The prolactins from the anterior pituitary and the oxytocin from the posterior pituitary. Prolactin helps in secretion of milk. It helps, these are the alveoli, and these get lactocytes. These get bigger as time passes, and milk is produced in them. And then through the ductules, these come out under the influence of oxytocin. And oxytocin is produced by the posterior pituitary. So as I said, prolactin helps in the production of milk. Oxytocin causes ejection of milk. Then there are reflexes in the baby, rooting reflexes, sucking reflexes, and swallowing. prolactin, what influences the secretion of prolactin? When the baby sucks, there is a sensory impulse from the nipple going to the anterior pituitary, and it causes prolactin to be excreted in the blood, and more milk comes out. What we have to remember is that it's secreted after a feed to produce the next feed. So better empty, more prolactin. More prolactin is secreted at night. So what are the factors that enhance it? Emptying of the breast, sucking by the baby, expression, basically emptying of the breast, and feeding at night. All these help in prolactin secretion. And what hinders it? Bottle feeding, incorrect position, painful breast. Okay. And certain medications. Now, oxytocin is excreted by the posterior pituitary. That helps in the milk ejection reflex, and it works on the myoepithelial cells which surround the alveoli, and that will contract and lead to milk being going into the lactiferous ducts. So oxytocin contracts the myoepithelial cells. When the baby is sucking, there is a sensory impulse which goes to the posterior pituitary. There's a let down and the baby sucks. Just like prolactin, oxytocin is also influenced by many factors. When the mother is confident, the sight of the baby, good feelings, positive feelings, these help oxytocin secretion. Any worry, stress, doubt, these will hinder the reflex. So that is when engorgement occurs. Milk may be there, but the letdown doesn't occur. So signs and plus oxytocin helps the uterus to contract. So what are the signs and sensations of an active oxytocin reflex? The mother may feel a squeezing or tingling sensation in her breast just before she feeds her baby. Milk flows from her breast when she thinks of her baby or hears him. Milk drips from the other breast when her baby is sucking on one side. And pain may also occur from uterine contractions during feeds in the first week. Then on the baby's side, because the baby is getting milk, slow, deep sucks and swallowing which show that breast milk is flowing into the mouth. Now, what are the reflexes in the baby which help in the feeding? One is rooting reflex, in which especially the side of the mouth, the cheek goes against the breast of the baby. The baby opens the mouth and goes searching. You can see, remember the video that we saw. Okay. Sucking reflex, this is a definite way in which the whole nipple and the areola need to go against the palate, and then the baby will press on the lactiferous ducts which are here, and this will enable milk to flow. And once it comes in the mouth, then the baby swallows. Dr. Rosalind has a very nice video which she'll be showing in the next talk. So to put it together, for successful breastfeeding, we need a willing and motivated mother. We need an active and sucking newborn. We need a motivator who can bring both mother and newborn together. Obviously, a close relative is the usual person when the baby is given to the mother. But as nurses and as doctors, we are also quite often there when the baby goes for the first feed. And we have to see, how is the interaction? Is the mother holding, how is she holding the baby? Is the baby's body close, facing the breast? There are some positions which we'll go into in a little while. And always it should be face to face with attention from the mother. Plus, how does the mother hold her breast? If you remember, actually there used to be we used to say that the sinuses are there, but actually the ducts are there right under the nipple. So the fingers should not go right on the nipple or the areola. They should come in a C against the chest wall, and then her first finger forms a support at the base of the breast, and then she can, this is also important when we're talking about expressing breast milk. So the other signs are Other ways of having a successful breastfeeding is having a written breastfeeding policy. Little more I'll tell you during the talk about BFHI. Motivate the mother from the antenatal period. So from the time she comes to the OP, we should be giving an input about this. Put to breast within 30 minutes of birth. This is like a government policy now. Promote rooming in of mother and baby and promote frequent breastfeeding. Okay. Now, what do we mean by frequent breastfeeding? We say on demand, but we need to have some spacing so that the breast can fill up. So the first breastfeeding provides skin-to-skin contact from the moment of birth. So that, we saw from Dr. Devakar's video. Do not separate the mom and baby. Okay, it's really important, both for the mother and for the baby. Vitamin K, hepatitis B, everything else can wait until after the first feeding. Ideally, the first feed should happen within 30 minutes while the baby is quiet and alert. And it doesn't matter if it's not optimal, but both should be motivated. The other points are, don't give pre-lacteal feeds. The baby does not require anything else. Do not use a bottle to feed. Support the mother in breastfeeding. We have to be encouraging, and they have to realize quite often the relatives are far better, but sometimes they are also the problem. So we need to be diplomatic. We can have mother classes in health facilities and treat whatever problems come early, and exclusive breastfeeding till 6 months and addition of home-based semi-solids after 6 months. So now we talk about position and latching. Now the position is critical. Infant obviously needs access to the breast. Both the mother and infant need to be comfortable. And we commonly recommended positions include cradle, cross cradle, football, and sideline. And laid back breastfeeding has also been promoted. Now thinking of the mother, make sure that she has good back support. Use a roll in the bed or sit in a chair which has got a support at the back. Give lots of pillows for her elbow. And to prevent back strain, we can even keep a footstool. Now the commonest position is the cradle hold. We position the baby at breast height, roll the baby belly to belly, which means tummy to tummy, abdomen to abdomen, nose to nipple. Basically, the baby has to be straight, facing the mother, and let the baby's head be in the bend of the elbow or on the forearm. So the cradle hold while the mother sits in a chair. Infant's head and body are supported by the forearm. Sometimes you can use a pillow to support. The baby's stomach, as you can see, should be flat against the mother's chest, and the baby's head should be in line with the body. So we have one straight line, okay, like this. The mother's free hand, which is here, this one, supports and guides the breast to the infant's open mouth. And the thumb of the free hand may be placed on top of the areola like this. And the breast supported with the cupped fingers, basically C. So it should be away from the nipple so that the thumb and fingers do not come in the way of the latch. Okay. So this is the commonest one that we talk about. And she has one hand for supporting the baby, and make sure that she has enough support in other places. Okay. Second is a football hold. And here, I'll just show you. Okay, so this is again always straight, and we can see the baby easily. And this is usually used if the mother has an abdominal incision after a cesarean, those with a large breast or with a small baby. This baby is supported by a pillow, and in fact, we can do twins by using this way. one on each side, football position. Okay. Baby's body and legs are under this right arm, you can see, and the head is supported by the mother's right hand. And here the free hand supports and guides the breast to the baby. So this is for a smaller baby or for twins. Then there's a cross cradle position. Roll up the belly to belly, nose to nipple, and we hold the baby's head behind the ears. So this is which is also used, but then it's a little more awkward to be used. Mother's free hand supports. Okay. Now latch. During the latch, the infant's lips form a tight seal around the nipple and most of the areola near the lower lip. Okay. And if it's an effective latch and milk transfer, so the nipple and the areola go in, the mother and baby feel completely comfortable. The mother feels the tugging, but no nipple rubbing, no pain. Infant's mouth is open like it's yawning, and more areola is seen near the infant's nose than near the jaw. So this goes completely, there's like outturning of the lower lip. Nipple high in the infant mouth, much closer to the infant's nose. The chin touches the breast, and the nose is near, but not necessarily not touching the breast. Swallows can be audible, and once the feeding is over, the breast feels soft, and the baby is content after a feed. So this is a good attachment. This is a poor attachment, okay? Because only the nipple, here the full areola as much as possible also comes in. So the baby's mouth is wide open, baby's chin touches the breast, the baby's lower lip is curled outwards, and the lower portion of the areola is not visible. Okay, 3 slides on latching. Okay, if you don't have a poor attachment, there is pain and damage to the nipples and sore nipples and fissures. Breast milk is not removed effectively because the baby has to suck at the ductules which are just under the areola and leads to engorgement. There appears to be poor milk supply because it is not being ejected out, and baby is unsatisfied, frustrated, takes the breast, because it's not emptied, makes less milk, and the baby fails to gain weight. So what is, and sometimes we cannot give direct breast milk, and we need to give expressed breast milk. And it can be mother's own milk, or it can be pasteurized human donor milk. Okay. There are certain indications for giving expressed breast milk: sick mother, local breast problems, a preterm or a sick baby, or a working mother. These are stored in wide mouth containers, can be kept at room temperature for 4 hours, in the fridge for 24 hours, and in the freezer for 3 months. The milk banking has come up in a big way. I will not be talking about it because I believe the next module they will be talking about it. But we need to know that there is a concept of expressed breast milk. Okay. Now, this was in terms of anatomy, benefits, physiology, latching and positioning. There are certain concepts and certain words that everybody talks about. One of them is the BFHI, which is the Baby Friendly Hospital Initiative, which was brought around in 1992. It was basically by the WHO and UNICEF. And the idea was to encourage breastfeeding and discourage any kind of artificial formula or accessories, which means bottles, pacifiers. There's something because of nipple confusion. And because of the fact that there is a high incidence of infection, diarrhea, a lot of other problems. Whatever it is, we've seen that the deaths from diarrhea have decreased 14 times wherever there's been pure breastfeeding. And similarly, malnutrition, sickness, all these numbers have come down a lot. So because of that, the idea is that every hospital should be a baby-friendly hospital. And there are 10 points which are usually put up on the walls wherever newborns are there and wherever the antenatal visits occur. So basically what it entails is that every facility providing maternity services and care for newborn infants there are 10 points. The first point is have a written breastfeeding policy that is routinely communicated to all healthcare staff. So the breastfeeding policy being that the babies go, there's only breastfeeding, no other formula, no water for newborns. Babies are fed within the first hour of life. Babies are kept with the mother as soon as possible, and they are roomed in with the mother. These are whatever is the policy in a hospital. Okay. And anybody who comes to work in that hospital should be knowing it, especially the nursing staff and all the medical staff. Okay. Whether it be doctors, junior doctors, consultants. Train all healthcare staff in skills necessary to implement this policy. So, like I told you, we're talking about position, latching. All this needs to be imparted by seeing, by doing, by teaching. Okay. Inform all pregnant women about the benefits and management of breastfeeding. So the obstetrician and the antenatal caretakers also have a role in that. They have a definite role because the mother has been seeing them for 9 months. We come into the picture later. So once they know about the benefits, they are open to it. Because the pharma company, maybe around 20 years ago, had just, exploded in the world and with all their marketing. I'll come to the next point I want, but right now let me talk about the BFHI. Next. Help mothers initiate breastfeeding within half an hour of birth. Show mothers how to breastfeed and how to maintain lactation even if they are separated from their infants. So we need to teach them how to do expressed breast milk, how to express breast milk in case they cannot be near their babies. Give no food or drink unless medically indicated. Practice rooming in, allow mothers and infants to remain together for 24 hours. Encourage breastfeeding on demand. We usually say, a pattern gets picked up after some time, but we need to give some time for the breast to fill up. As I told you, hind milk has got higher fat content, satiety value. So because of that, if you want the breast to fill up, we need to give at least an hour or two between feeds. And then let the baby feed as wanted, usually about 10 to 15 minutes one side and another 10 to 15 minutes. And one side, once it's emptied, next time always the other side should be fed. Give no artificial pacifiers, dummies, soothers to breastfeeding infants. Otherwise there is nipple confusion, there is infection. Okay. And foster the establishment of breastfeeding support groups and refer mothers to them on discharge from the hospital. So these are the 10 points which you'll see in every local language, in every postnatal ward, labor room, everywhere, BFHI, 10 points. Okay, then there's another thing which is known as the IMS Act, or the Infant Milk Substitute Feeding Bottle and Infant Foods Act 1992. Which was amended in 2000. So the objectives of this are to prohibit any, kind of promotion of artificial formula, educate pregnant women and lactating mothers, restrict and control the use of infant milk substitutes and infant foods, define roles and responsibilities of healthcare institutions and health workers. There's a list of what is known as violation, of the IMS Act. And if any infant food company promotes this, distributes, gives inducements, then this is against the law. It's a violation of the act can lead to penalties of imprisonment and fines. So these are things that the world bodies, our government has done to promote breastfeeding. The latest is Mother's Absolute Affection, or MA, which is the latest program for promotion of breastfeeding. So breastfeeding is every baby's birthright, and we owe it to them.
Hello, I'm Dr. Rosalind, and I shall be speaking to you today on common problems in breastfeeding. Breastfeeding is central in neonatal care, and all mothers require support in the initial few days of breastfeeding. The nursing personnel play an indisputable role in helping mothers during breastfeeding. So I hope this video will help you in your clinical day-to-day practice. There are many different shapes and sizes of breast and nipple. Babies can breastfeed from almost all of them. I want to remind you of a few etiquettes while approaching a mother during breastfeeding. Introduce yourself, explain what you want to do, ensure privacy, ask permission. If touching the breasts, be gentle. Build mother's confidence and never be critical about her breast. Milk in the breast is produced in the acini, and the milk will drain via the lactiferous ducts into the large lactiferous ducts and the sinuses. And then it opens to the nipple. So milk is not present in the nipple. It is stored in the large lactiferous ducts and sinuses, which are present under the uvula. So when you help a mother breastfeed, you have to ensure that the jaws of the baby surround the lactiferous ducts and sinuses, which are underneath the areola, and the nipple and the large part of the breast tissue is drawn into a teat, which is deep into the baby's mouth. The tongue surrounds the nipple and cups it, and the end of the nipple is free. The tongue does not brush against the tip of the nipple, which causes the nipple to become sore. Why does a shallow latch cause nipple pain? This is because when the breast tissue is not appropriately into the baby's mouth, the baby's gums chomp on the nipple, the baby's tongue rubs against the tip of the nipple, which is like sandpaper, and causes the nipple to become sore. In a deep latch, the baby's gums are against the areola, where the skin is tougher. The baby's tongue is wrapped around the length of the nipple and is cupping the nipple and not rubbing against it. So position the baby so that its tip of the nose is near to the nipple, and when the upper lip rubs against the breast, the baby will open his mouth. And when he does so, keep the baby close to the breast and ensure that as much of the nipple gets into the baby's mouth. So a large portion of the breast tissue is in the baby's mouth, and he begins to suck. The nipple is in the soft part of the mouth. So how can we assess that the baby is properly attached? You see the baby's chin touching the breast, the mouth is wide open, the lip turned outward, and more areola is visible above than below. And there will be no pain, the mother will be comfortable. In poor attachment, the chin is separated from the breast, the mouth looks closed, the lower lip is pointed forward, and more areola will be visible below the mouth and lower lip, and there will be pain while feeding. In addition to attachment, you must make sure that the baby is also properly positioned. So in good positioning, the neck of the baby is straight or bent slightly back. body is turned towards the mother, body is close to the mother, and the stomach of the baby is close to the stomach of the mother. The whole body is supported, and there is eye contact between the mother and the baby. In poor positioning, as you see in this picture, the neck of the baby is twisted or bent, the body is away from that of the mother and not kept close. Only his head and neck are supported, and there is no eye contact. So ensuring good positioning and good attachment goes a long way in ensuring adequate feeding. Now we come to common breast problems. So first is, as most of you will, when you do your rounds, you usually come across the most problem being insufficient milk. Now, majority of time, the mother perceives that the milk is insufficient because the baby is crying a lot, wants to feed very often or for a long time at each feed, or she says that her breast feels soft or she's not able to express her milk. In majority of cases, most of these problems can be solved if you correct the faulty feeding technique or faulty feeding pattern. Now, sometimes the milk may actually be low. There will be low breast intake, and the two most reliable signs of this are poor weight gain and decreased urine output. So, a neonate should regain birth weight by 7 to 10 days and should pass at least 6 to 8 dilute urine in a day. So, the low milk intake could be due to breastfeeding factors like delayed initiation of breastfeeding, poor attachment, infrequent feed, short feeds, using bottle or pacifiers, and giving other feeds. Or psychological factors in the mother. She may lack confidence, and we have to support her and give her a lot of confidence in feeding. She may feel depressed or stressed and have lack of sleep. Or she may be having a physical illness. So how do we manage it? We have to develop our counseling skills. And the most important part of the counseling is listening. So listen to the mother and understand her difficulty. Take a feeding history, observe a breastfeed, and that is very important. You have to observe the breastfeed, ensure proper attachment and positioning. Once the attachment and positioning is proper and the mother is comfortable and is able to feed the baby without pain, most of their problems can be solved. It is very important to emphasize that she should completely empty her breast before offering the other breast. We know that the hind milk is rich in protein and fat and contributes to satiety. So she should completely empty the breast and offer the next breast for the next feed after 2 to 3 hours. Mother's psychological and physical well-being should also be taken into account. So the most important part of management is to build the mother's confidence in her milk supply. Should advise her to also take rest and plenty of fluids. I re-emphasize that all infants should regain their birth weight by 2 weeks of age. If an infant is below his or her birth weight at the end of the second week, this needs to be assessed. Now, most mothers on 3rd and 5th postnatal day, when the milk comes in, will say that she feels her breast is heavy, hot and hard. But the breast is not painful and the milk flows well and drips from the breast. This is normal. So encourage the mother to breastfeed frequently to empty her breasts, and after a few days the milk production adjusts to the baby's needs. Another common problem is sore nipples. So the symptoms are severe pain while feeding, and on examination you find a visible fissure across the tip of the nipple or around the base. And the most common cause is poor attachment. Some mothers frequently wash their nipples with soap and water before feeds, and in rare cases it can be due to candida infection. But the most common cause is poor attachment, with the tongue of the baby rubbing against the tip of the nipple. How do we manage this state? Help mother improve baby's position and attachment. So it is very important to continue breastfeeding, and you can apply breast milk, especially the hind milk, after the feed is over and expose the nipple to air. In breast engorgement, the breast will be swollen, edematous, the skin looks shiny and red. The breast will be warm and hard, and unlike fullness of the breast becomes painful. The nipples are also stretched and flat, and the mother can have fever. The cause is basically infrequent removal of milk due to either delayed starting of breastfeeding or poor attachment and incomplete emptying of the breast. So it is prevented by starting breastfeeding soon after delivery, ensuring good attachment, and encouraging unrestricted feeding. So this is a schematic. A normal breast which is not engorged will feel soft and mother is comfortable, while an engorged breast in which the milk accumulates in the acini and the ducts will appear full and hard, and even the nipple becomes flat. So this can cause problems in latching. So how do we manage this? The fundamental principle is removing the milk from the breast. If the baby is able to latch and suckle, breastfeed frequently. The baby is not able to suckle, express some milk by hand or a breast pump, and once the breast is softer, breastfeed the baby. And after feeds, applying cold compresses on the breast will help to reduce the edema and the pain. So you can apply a cold cabbage leaf or a cold gel pack. Another common and frustrating problem for both mother and nursing staff is a retracted or inverted or a flat nipple. So an inverted nipple describes one that retracts into the breast instead of pointing outward. The nipple is held by tight connective tissue, but the good part is it can slacken after baby starts suckling from it. So this is a schematic of the types of nipples. This is a normal pointed nipple, and as the nipple is inverted or held back by connective tissue, it can grade from being flat to totally tucked in, and this is a grade 3 deformity. How do we assess for nipple inversion? So a inverted nipple, you try to pull out the nipple by finger pressure. If the nipple remains protruded and remains so for some time, it is a grade 1 nipple, and most probably you will be able to breastfeed. Because you should remember that the baby does not feed from the nipple but from the breast. If the nipple protrudes temporarily but retracts after release, it is a grade 2 retracted nipple. And if it is not protractile, then it is a grade 3 nipple. So this is a schematic where you see that in a normal nipple, the nipple sticks outward and the ducts empty into its tip, while in a retracted nipple, it is kept retracted or held retracted by underlying connective tissue. And this is how an inverted nipple will look. So how do we help these mothers? Help the mother to position the infant and try to attach her baby to the breast by grasping the breast tissue such that the areola forms a teat. If a baby cannot attach, the mother can express her breast milk and feed the baby by cup or palm. Now it is important to explain to the mother how she can express milk from the breast. So the first step is to massage or stroke the breast. Position the finger 1 inch behind the areola such that you form a C, and the tip of the fingers, the thumb and the forefinger are directly opposite to each other. Press backward towards the chest and then compress the fingers together. That is, bring the thumb and the forefinger together. After a few attempts, milk will start coming as drops. You should never bring the thumb and the forefinger over the areola or the nipple. This will cause pain to this area, and that is not the correct technique. So the thumb and the forefinger should remain away from the areola when you press. Again, massage and stroke the breast and change the direction of your fingers to another position. Press backwards toward the chest and express by bringing the two fingers closer together. This can be done with different positions on the breast and express until the milk flow stops, and it can take up to 20 to 30 minutes. You can also use a manual breast pump. Once you've taught the mother how to express the milk and taught her palda feeds, she can try to correct her nipple by the inverted syringe technique. Here, a 20 ml syringe is cut along the adapter end or the nozzle end by a sharp blade. The plunger is removed and reinserted from the cut end. The smooth end of the syringe is placed against around the mother's nipple, and she gently pulls the plunger. She has to be trained how to do this, and she has to do it every day, and the nipple gets corrected in around 2 to 3 weeks time. Now we shall go to another set of conditions which are all caused by milk stasis. So these conditions can range from a blocked duct to milk stasis to non-infective mastitis and finally an infective mastitis. So what is a blocked duct? A blocked duct presents as a localized tender lump in one breast with redness of skin over the lump. That is due to an occlusion or a plug forming in the milk passage. So this is due to infrequent feeding, poor attachment, tight clothing, or trauma to the breast. So we can manage this by improving drainage of milk from the affected part of the breast. Continue the breastfeeding, that is very important. Ensure baby is well attached. Gently massage blocked or tender area down and toward the nipple before and during feeds. Sometimes you might find a thick plug of milk coming out, and after that there is free flow of milk as the stasis is relieved. And avoid pressure from tight clothes. If milk stasis continues, it can lead to mastitis. In mastitis, the milk remains within the acini and the ducts, and the surrounding breast tissue becomes inflamed. It presents as a localized unilateral painful breast which is tender and erythematous, and the mother will have fever and feel ill. The cause is again milk staying in the breast, resulting in a non-infective inflammation, and so infection supervenes if stasis persists or a nipple fissure becomes infected. The cause is again due to long gaps between feeds, incomplete removal of feeds, unrelieved engorgement, poor attachment causing nipple fissures, blocked milk ducts, tight clothing causing pressure on a part of the breast. The management is by improving the removal of milk from the breast. So continuing breastfeeding, there is no risk of infection to the infant. Mother can be given analgesics, preferably ibuprofen or paracetamol. And if symptoms are not relieved in 24 to 48 hours, antibiotics can be started. But remember that antibiotics are not effective without milk removal. And if a mastitis is not appropriately managed, some mothers go on to develop a serious condition called breast abscess. It presents as redness, swelling, and pain in an area of the breast. Mother will have fever and feel ill, and on examination, a well-defined fluctuant lump is seen in the affected breast with enlargement of the draining axillary lymph nodes. The cause is by infection of a segment of breast, most commonly by Staphylococcus aureus, and usually follows a mastitis that was not appropriately managed. So this is managed by, once an abscess develops, it has to be drained, either by incision and drainage, or, as in most recently, by aspiration of the pus, which may be ultrasound guided. And the general measures are analgesics for the pain. Breast support is very important, for that also relieves pain. The mother must continue breastfeeding from the normal side, and the affected side must be emptied mechanically. After a drainage of the abscess, the breast will heal in 7 to 10 days, and if the milk that is expressed is free of pus and blood, the baby can be fed from that breast as well. And anti-staphylococcal antibiotics may be required for 10 to 15 days. So this comes to the end of the presentation, and the take-home message would be: the key to successful breastfeeding is building the confidence of the mother. Thank you.
Greetings to all from MOSC Medical College, Kolancheri. I am Dr. Manu Rajan. Today our topic for discussion is breastfeeding in COVID-19 perspective. As you all know, COVID-19 is the short form for Coronavirus Disease 2019. It is a respiratory virus. It is a single-stranded RNA virus in coronavirus family, named after the morphology. The full form of the virus is Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. It was first reported from Wuhan, China in December 2019. WHO declared a global pandemic on March 11, 2020, following its rapid spread all over the world. With the rapid spread of COVID-19, there arose some uncertainty, panic, and confusion in our society. Such uncertainties have also crept into the breastfeeding practices. We all know that breastfeed is the best feed that you can give for a baby. But in this corona perspective, we are doubtful whether breastfeeding can be done as usual. In answering this question, we have to have some considerations kept in our mind. The first question is, how is COVID-19 transmitted? Is there any transmission through breast milk? Can a COVID positive mother give direct breastfeeds? What if the mother is sick and cannot feed? What are the precautions to be taken? We will go through each of these in a short while. First, how is COVID-19 transmitted? As I have already told, COVID-19 is a respiratory virus. The primary mode of transmission is by contact and droplet transmission. Any direct, indirect, or close contact with infected people or their infected secretions, such as saliva or respiratory secretions, can transmit infection to a susceptible person. Next is airborne transmission. Airborne transmission is defined as spread of infectious agent caused by dissemination of droplet nuclei or aerosols that remain infectious even when suspended in air over long distances and time. Next is fomite transmission. The respiratory secretions from an infected person can contaminate surfaces or objects. These objects can cause disease to another susceptible person. The biological samples such as urine and feces of infected persons have also been shown to be infective. Now the main question, is there transmission of COVID-19 through breast milk? There are various small studies available answering this question. Several case reports have come from China, some have come from various parts of the world answering this question. Most of them report that coronavirus, a viable coronavirus, is not isolated from breast milk, but the nucleic acid of coronavirus have been isolated. We need more research into this field to answer the question more clearly. As I have shown in this slide, all of these organizations support and promote breastfeeding even through these corona times. The World Health Organization, UNICEF, CDC, even our Indian organizations like NNF have set up their own guidelines to promote and support breastfeeding during these corona times. Next question is, what if the mother is COVID positive? If the mother is corona positive, the bystanders may have a genuine doubt whether the baby can be breastfed. So the healthcare worker must be able to allay their doubts and explain to them the risks and benefits of breastfeeding. The decision of whether and how to start breastfeeding is taken after taking the family also into confidence. The WHO in its scientific brief advises mothers should be counseled that the benefits of breastfeeding substantially outweigh the potential risks of transmission. Mother and infant should be enabled to remain together while rooming in and to practice skin-to-skin contact, especially immediately after birth and during establishment of breastfeeding, whether they or their infants have suspected or confirmed COVID-19. In short, WHO says that mothers should be supported at birth to practice skin-to-skin contact, initiation of breastfeeding within 1 hour of birth, supported for rooming in, supported for breastfeeding exclusively. They should be taught appropriate infection prevention and control measures. What are the precautions to be taken by a COVID positive or suspected mother? They should learn to clean their hands. Before touching the infant, they should wash their hands for at least 20 seconds. If a sanitizer is used, they should use a product containing at least 60% alcohol. What are the steps to prevent droplet infection? As I have already told, coronavirus can easily spread by droplet infection. So the mother should make it a habit to wear a medical mask prior to breastfeeding the baby. She should also learn to practice respiratory hygiene, that she should cover her mouth and nose while coughing or sneezing. Then she should learn to disinfect commonly used surfaces. What if the mother needs to be separated for treatment purposes? If the mother needs to be separated from the baby for treatment purposes, she can provide breast milk to the baby by expressing it. This expression can be by using the hand or using a breast pump. In both of these situations, mother should use hygienic practices and clean all the surfaces which are in use. Is there any advantage by sticking with exclusive breastfeeds? The answer is yes. Breastfeeds contain many antimicrobial factors like secretory IgA, IgM, IgG, oligosaccharides, lysosine, leukocytes. So whenever a mother gets an infection, she produces cellular and humoral immunity. This secretory IgA then transfers to the baby through the breast milk and provides passive immunity to the baby. The immunoglobulins secreted in the breast milk are an immunobooster for the baby. What if the mother is unwell to express breast milk? If the mother is unwell that she cannot express breast milk, we should consider other avenues. Relactation can be tried, that is breastfeeding after a gap. We can try pasteurized donor human milk. We can try wet nursing. All of this will depend on the cultural context and the availability of facilities. What if the mother is on pharmacological treatment for COVID-19? We have come across several medicines which we use for treatment of corona, like azithromycin, hydroxychloroquine, lopinavir, tocilizumab, methylprednisolone. All of these are excreted in very small amounts in the breast milk. There are no specific studies which establish the safety of these medicines, but there are no contraindications for breastfeeding even if the mother is on treatment. What is the role of health workers? Health workers can give breastfeeding counseling during antenatal period. They can allay their doubts regarding breastfeeding even if the mother is corona positive. They can provide appropriate support to initiate and maintain breastfeeding. They can support the mother if she is sick to express breast milk. They are instrumental in providing counseling at discharge so that mother will be able to exclusively breastfeed the baby for the first 6 months of life. In conclusion, all available literature at present highlights and promotes the role of exclusive breastfeeding and rooming in even during this COVID-19 pandemic. Thank you all for your patient listening.
So this brings us to the end of today's session. We've not gone into too much depth because it is a huge topic. It may seem simple, but for a baby, after breathing, feeding is the next thing to do. We all eat to live. They live to eat and eat to live. We hope we have helped you along the way. Some breastfeeding workshops run for 10 days because there is a multitude of questions that may come up. Please, I do ask you to ask whatever you want. Nothing is silly. From whatever experience we've had, 10, 20, 30 years of doing this job, we will try to answer to the best of our abilities. You are the first person who will interact with the mother 99% of the times. So let us make it a pleasurable experience for both mother and baby. Thank you.